To kick it off, we're going to start off with Dr. Yasser Bhat, who is the Director of Interventional Endoscopy at Palo Alto Medical Foundation. I am in the interventional endoscopy world myself, and unfortunately, I've not had the pleasure of meeting Dr. Bhat personally, but his reputation certainly precedes himself as one of the most skilled and also one of the most approachable advanced endoscopists in the Bay Area. Today, we decided to ask him to speak about two topics that are deceptively challenging within the GI world and pancreatology in general, and that would be pancreatic cysts and EPI. With the changing guidelines in pancreatic cyst management, there's usually a general unease in the community as far as how best to address these cysts, when to stop screening, and how to advise patients, especially with pancreatic cancer being on everyone's mind. So we asked Dr. Bhat to shed some light on this topic and tell us the current state of the art. So Yasser, I'll let you take it away from here. Thank you so much for joining us this morning.
Thank you very much, Suraj, Nikhil, Radhika, and the rest of the organizing team for inviting me. I have to share screen, so let me do that. Okay, so that should set me up. Okay, thank you very much again. This, as Suraj said, this is a deceptively tricky topic, right? Because pancreatic cysts being so ubiquitous tend to be something that we think are par for the course, but when you really start digging into each cyst, you realize that every single patient and every single situation is very individual. But let's start with something that almost everybody here has probably been exposed to, where you get a report. This is a true MRI report, and this is actually from several years ago, where I was so impressed that this MRI had picked up a 2 millimeter focus, and that's literally a pinhead. This was thought to be a small pancreatic cyst, and the referral came in for that. And this just shows to highlight the quality of imaging. Cross-sectional imaging has improved leaps and bounds over the last 20, 30 years. And incidental findings continue to go up. Even as far back as 2002, 20% of patients getting MRIs for non-pancreatic indications were found to have pancreatic cysts. And I would only say that number is probably in that range, maybe a little bit higher. So all of us will see these. And it's for good reason. 25% of patients undergoing an autopsy for non-pancreatic reasons harbored cysts. And it also reflects in the surgical series. The largest surgical series come from MGH. And if you look at their data from 1997 to 2002, 37 of their surgical series had incidental cysts, and that bumped up from the 2003 to 2007 range, probably related again to better imaging and more intervention. Which really then, anytime you see these cysts or you see a report like this, it raises two questions in your mind. What cysts do you remove and which ones do you observe? And how can imaging and maybe enhanced endoscopic techniques help you with this decision? And ultimately, it's about the potential on either side. On one hand, we have the potential to prevent or detect early pancreatic cancer, which, as we all know, in this disease is the best chance of cure. And on the other hand, there is the potential to create harm by aggressive treatment, particularly surgery. I'll say at the outset, while surgery is curative in all preneoplastic cysts, it's not a benign procedure with morbidity in the range of about 40% and a mortality rate of on average about 2 to 3%. So that balance is really what this discussion is all about, and that's what I think creates all the anxiety. To understand that, let's quickly look at what pancreatic cysts actually entail. There are the cysts that carry no epithelial lining, and these are pseudocysts. Won't go into that. But the ones of interest to us are ones that have a true epithelial lining. Those can be divided into benign malignant and pre-malignant cysts. Benign cysts, the classic one is a serous cyst adenoma, but there's other ones like lymphoepithelial cysts or retention cysts or foregut cysts that can happen in the pancreas. Pre-malignant cysts are solid and pseudopapillary tumor and the mucinous cysts. This is the MCN and the Ipmn. And malignant cysts can be mucinous cyst adenocarcinoma or Ipmn carcinoma. And then the others that we are familiar with, which is ductal adenocarcinoma with cystic degeneration or other solid tumors with cystic degeneration, in even neuroendocrine tumors that might present with a cystic appearance on CT scan, but those are already malignant. So that's sort of the overview. And the incidence of among the cysts that the cystic neoplasms, again going back to the large MGH series of over almost 20 years, the distribution seems to be 50% of these cysts are Ipmn, the ones that eventually go to surgery, 30% being branch duct, and 20% being main duct. Now, this is a little bit older, and we'll discuss a little bit about why this might change. But in general, Ipmn will carry about 50% of, or most of 50% of patients who have surgery will have some form of Ipmn. In their series, interestingly, the serous cyst adenoma resection rate was 20%, and this was before the advent of some of the more sophisticated techniques we have now. So this number should be lower now. And the MCN and mucinous cyst is that stayed stable in the range of about 10 to 15%. So about 70 to 80% are these cysts, and then you have the other smaller cysts, which includes a very rare thing called a solid pseudopapillary tumor or cystic islet cell tumors, etc. For the benefit of the audience, some of this may be a little repetitive and basic, but I think it's important to go over that quickly. Serous cystic tumors are in this diagram, in this cartoon here, you can see them. They have this classic honeycomb appearance. They've got a bright central scar, though not all of them have it. And they can be a microcystic variant where you've got an appearance like this, or they could be somewhat oligocystic or macrocystic, whereas these cysts coalesce and there's less septations. Those can be a little bit more confusing, can be confused with branch duct Ipmn. But if you have an appearance like this on a CT scan, fairly large, somewhat scary looking lesion, maybe a central scar there, and then you do an EUS and you find an appearance like this with honeycomb and thin septations, these are often, when you look at them in the US, it's pathognomonic for a serous cyst. The FNA of these lesions, because of the nature of the cyst, if you get into that pocket or that, and you may have to move the needle around, moving the needle around creates bloodiness. So you get often thin serous fluid, usually bloody. And if you get enough, the pathologist might see glycogen-rich cuboidal cells. That's a clue. May see macrophages, foamy macrophages. That's the other thing they might report. And on cyst fluid analysis, they usually have a low CEA. And the key is the newer techniques let us know that if they have a mutation in the VHL gene, and that if you have that positive on a molecular analysis, then you know you're dealing with a serous cyst, and it's a benign cyst usually, and until they're symptomatic, you would not even observe them, and you could reassure the patient. As opposed to a mucinous cyst, this is MC. Within mucinous cyst, the two broad categories are the MCN, has a female predilection of about 8 or 9 to 1. These are considered pre-malignant lesions. They can be septated thinly. They can be unilocular or multilocular, although they're not usually honeycombed. The classic board question might be something with an eggshell calcification, although that's only present in about 20% of these patients. And on a CT scan, they might look something like that. And on an EUS, you can see a much more unilocular type of a cyst. And therefore, if you put a needle in there, you get a lot more fluid, which you can then send for analysis and molecular. The one requisite, ideally, if you see ovarian stroma on your pathologist's report in cytology, that is very pathognomonic for MCN. And resection recommended, I put that in italics because it's when we go later to the guidelines, you'll see that this is something that's considered, these cysts should be resected, but I think there is debate and controversy around that, particularly in the last couple of years, which is important. The other category of mucinous is intraductal papillary mucinous neoplasm, or IPMN. These have no gender predilection, are also considered malignant, pre-malignant lesions. There's two main types. The main duct IPMN is considered much higher risk. That would be that. You see that CT scan where the entire pancreatic duct is dilated. You can maybe even see some hyperechoic mucinous globs here. And you see that there's really not much pancreas left around it, because it does create a form of chronic pancreatitis where there is concurrent atrophy of the gland and dilation of the duct. So that's a very classic main duct IPMN. This, of all the cysts we talk about, will have the highest risk of progressing to pancreatic neoplasms and cancer. So these would be ones that we would recommend resection for, particularly if they have symptoms or the duct size, et cetera. And we'll go with that a little bit later. Branch duct IPMN is a similar process, similar pathologic process, but that happens in the side branches of the ducts. And there is a third category called mixed, where you will have changes in the main duct or a portion of the duct, as well as the adjacent branches, and those are termed mixed. For branch duct IPMN, these are lower risk than main duct, can often be monitored, and actually are more often asymptomatic. And I will submit that majority of the patients that you will see that have scans that you have truly find pancreatic cysts probably fall into the branch duct IPMN category. They get more concerning when they're larger, develop solid components, or have symptoms associated with them. And there are specific CEA and mutational analyses that we'll discuss a little bit later that might help us identify these cysts and separate them out from the others. These are some more pictures to differentiate between side branch and main duct. This is an MRI picture. You might see a very bright sort of side branches that are dilated while the main duct's pretty thin. This is an ERCP image, main duct being thin, not dilated, but then you have these side branches sort of popping off the side of each on multiple side branches here. But on a CT and MRI, you might just have a single little cyst. US, you may see one cyst, and that's what we would target for aspiration. Main duct IPMN has a classic sign called the fish mouth ampulla. That's depicted here, where that main pancreatic orifice is wide open and you get globs of mucin coming out. When we see this with a side view or an ERCP scope, we're very sure of the diagnosis of main duct IPMN. But this only exists in about a third of patients with main duct IPMN. So it's not sensitive, but very specific. Again, that image there showing you the main duct's dilated. And this US image is of a duct that's dilated, but probably has a solid component here, which is more hypoechoic and darker. So what is the risk of invasive malignancy in these three different mucinous tumors? Main duct IPMN, as we mentioned, has the highest risk. And even now, 30 years after we know about these lesions, the exact malignant rate or risk is not clearly identified, but it's published literature shows it for anywhere from 30 to 70%. So I quote my patients a risk of 40 to 60% over their lifetime. Mucinous cystic neoplasm, or MCN, this has stayed pretty stable of lifetime risk of about 10 to 20%. And branch duct IPMNs are, again, a little bit all over the place, between 10 to 50%. Now, understand that all of these come from surgical series, because that's the only way to know for sure after you have the surgical specimen of what kind of cyst you're dealing with, but then there's a natural inbuilt surgical bias. So perhaps some of these risks are a little overstated. What tools do we have for diagnosis of pancreatic cysts? There is the standard EUS FNA, which allows you to aspirate fluid for CEA, amylase, and cytology. You can add molecular techniques to that, which would include a DNA analysis. People have also looked into something called microRNA analysis. I won't discuss that because that hasn't taken off too far and is not available in clinical practice, but DNA analysis certainly is. And some enhanced endoscopic techniques, which would include EUS-guided direct microcystic biopsy, EUS-guided cyst pancreatography, and and direct endomicroscopy. To understand the utility of any of these tests, it's important to quickly look at how pancreatic cancer develops. And the critical idea is that as that epithelial lining transforms from normal to PANM3 and to eventually invasive cancer, it's shedding material into the cyst lumen that we can aspirate and test for. And earlier, and a lot of work's been done to identify some of the mutations. For example, KRAS is an early mutation that happens in this process, as opposed to P53 loss and BRCA, which is a much later mutational LOH loss. So this is the whole idea. When we aspirate fluid from here, we're trying to look for CEA, we're trying to look for amylase, which allows us to identify connection to the main pancreatic duct. And then if you have the ability to send for molecular analysis, that can give you some information about that. But despite a lot of work in this area over the last 20 years, there is no silver bullet. There is no one test that'll just give you a quick answer. And we still live with this table that many of you are familiar with. And I'm just going to quickly go over this because I think it's important. You might see reports that have these to try and help differentiate between MCN, IPMN, serous cyst, and a pseudocyst, which is an inflammatory benign cyst for comparison. Because these cysts are mucinous, you're going to have high viscosity as opposed to these serous cysts and pseudocysts. Cyst fluid CEA was identified first by Dr. Brugge, and the classic number was a 192. We kind of accept now a cyst fluid level of 200 as being more specific for mucinous lesions. It tells you that the cyst could be mucinous. It doesn't really tell you anything about the risk of malignancy or if there is concurrent malignancy. So a cyst fluid level of 1000 doesn't mean it's any higher risk or there's higher transformation or higher grade lesion than a cyst fluid level of 250. It just tells you that it's more mucinous, and then you're dealing with either an MCN or IPMN. Cytology, they should be able to identify mucin, especially if they do muciramine stains. And in serous cysts, they might see PAS positive cuboidal cells. In practicality, these are more board type questions, and oftentimes in clinical practice, we don't find much utility in cytology. So I look at it, but it's not kind of the one that you'll get your answer from. And then cyst fluid amylase, this is to identify if there is a connection between the cyst and the main pancreatic duct, or is it a purely inflammatory cyst like a pseudocyst, which should be very high in amylase but low in CEA. Serous cyst adenoma and MCN usually do not connect with the main pancreatic duct, so we should have a low amylase in both of those. And between MCN and IPMN, the differential would be that they both have high CEA, but because MCNs do not connect with the main duct, they'll have a low amylase. That's a classic situation. In reality, again, never this clear, but something to keep an eye on, and another little piece of information that you would use in your calculus. Now, DNA mutational analysis is very interesting. This work started about 10, 12 years at University of Pittsburgh. Had the first study called the PANDA study looking at this, and they looked at a whole slew of different genomes, genetic markers and mutations. And for a while that got very complicated. And I'm sort of happy to now report that the latest data on this is more useful to share, because the mutational analysis seems to show that MCN and IPMN, being mucinous lesions, have KRAS mutations that are fairly specific, though not sensitive. Their sensitivity is about 60%, but they're pretty specific for mucinous lesions. And in addition to KRAS, if you also have a GNAS mutation, that's very specific for an IPMN, main duct versus side branch, but those are things you would be looking for, as opposed to having none of these, no KRAS, no GNAS, but having a mutation, the VHL gene. Then you know you're dealing with a cystic serous cyst. And this is useful because then you can reassure the patient and release them for the surveillance and observation. This test is not routinely done, the DNA analysis. It is run by a couple of companies. What we are doing is sending these directly to University of Pittsburgh. They have now commercialized their tests, and much like Mayo Clinic, where you can send tests to their lab, UPMC does have a cyst fluid DNA analysis program. The challenge sometimes is insurances do not cover this. They consider it experimental. So I don't routinely send it. We try to get insurance authorization prior to in the cyst that I'm interested in knowing this information. And if it's not available, then that cost has to be passed on to the patient. And it's anywhere in the range of about $750 to $1,000. But there are certain cysts where this is very, very useful, particularly ones that you're considering surgery and you're on the border, that money might be well spent. So it's not something that we're routinely sending, although I would like to send it more if insurances would cover that. This was the paper from Gastroenterology a few years ago that sort of helped settle some of these, what to look for. Again, just showing for serous cysts, VHL is what you're looking for solid pseudopapillary tumors. CTNNB1 gene is very specific. And for mucinous lesions, it's KRAS, and GNAS is more for, so GNAS is more for IPMN, is absent in MC, and that's the difference I wanted to show you guys there. And this is the, I don't want to go over a lot of this chart, but just know that that's available. That's actually a pretty good test when you can get it. Other things, this is a relatively new, although it's about 3-4 years old now, mini biopsy forceps that can be advanced through a 19-gauge needle directly into the cyst wall. It's made by, it's called the Moray, M-O-R-A-Y biopsy forceps, made now by Steris Endoscopy. Fairly easy to get it through the needle. And so you have a 19-gauge needle, you can direct the cyst. In this case, it's being directed over a little what's called mural nodule. You can actually see, and this is obviously publication pictures, so probably your best specimen, a fairly large piece. And then you get enough pathology data, in this case, carcinoma can be identified. So I've used this on occasion, particularly if it's a nodule like that, which is not a big nodule, not an obvious nodule, and the patient is a borderline surgical candidate in that scenario. It seems to be pretty safe. I'll tell you that the diagnostic yield is not as dramatic as one would expect, meaning if you don't have a nodule and you just biopsy the wall, are you getting a whole lot of information? Yes and no, it adds a little bit to cytology, but not, again, not a slam dunk. It might raise the rate from, the published data is from 47 to 62%. My concern used to be intercystic bleeding, but turns out that that's not an issue. It's minor. And in this paper from 42 patients, they had one patient who's bleeding. I haven't had any, but I've been fairly selective in whom I do this in. But it's something that I think can be considered in lieu or in patients where you're considering surgery. Direct cyst endomicroscopy or optical biopsy. For those of you that are familiar with the Cellvizio system, this is again a probe, a laser microendoscopy probe that can be advanced through the 19-gauge needle and applied against the cyst wall to try and create patterns, which are not easy to learn. And before you do this, you have to inject the patient with the fluorescent dye. But if you do get it right and it does look good, then what you're supposed to see is dye circulating through the blood vessels, and you might create images like that. A group of experts in this area got together and created criteria for what might be a serous lesion versus an IPMN. Serous lesions will have increased vascularity, and there was a question about some of these things, acinar cells, but really it's a pattern recognition thing where you're trying to find these cords with dye running through them, versus an IPMN where you might see, this is one that was reported as dysplasia, where I call them clumps. These clumps are darker and perhaps more prominent, and maybe that correlates with dysplasia. So this is a tool that's out there. It's obviously it has capital involvement and it's expensive to install. That adds a little bit of time to the procedure with the dye. You've got to wait about 10 minutes for it to circulate through. And my personal experience, this has not been something that has been as revolutionary as one would have wanted. So again, it's something that I don't use now in routine clinical practice. This is something that we had published on a few years ago, before the advent of molecular diagnoses. There used to often be a question of, is a lesion like this right there in the body of the pancreas, is that an MCN or a branch duct Ipmn? You've got a normal duct, you've got low amylase, but you don't know. So the idea here was that could you combine it and do an EUS guided ERCP and avoid decreased rate of pancreatitis, so you don't do retrograde cannulation of the main pancreatic duct, but inject the cyst with diluted contrast very gently and try and see if there's a communication. In this case, you can see that that cyst in the middle of the neck body area communicates on both sides with the pancreatic duct towards the ampulla as well as the tail. And then now you're dealing with a branch duct Ipmn, which you would not send to surgery, versus an MCN, where you were somewhat obliged to get a surgical opinion at the time. So that was the idea here. We didn't really see much pancreatitis with this. In a series of, I think, 20 patients that we did this in, there was one pancreatitis, which I wasn't sure was related to the procedure. This was from when I was with my own colleagues at CPMC. So that's kind of the diagnosis. So you get all of that together, and now you have to sort of decide what to do about these patients, and that's where guidelines come in. There are 5 separate guidelines available to us: the AGA one from 2015, the IAP, or the International Association of Pancreatologists guideline. These used to be the Sendai ones from 2006, and then Fukuoka in 2012, updated in 2017. ACG came out with their guidelines, and those are the latest ones, 2018 in European Study Group, and as well as American College of Radiology. All of these guidelines are, they have, the good news is they have some similarities, which we can all take and learn and use, but they also focus on different populations. And for example, the American College of Radiology is more focused on what you would use for surveillance and what are the criteria. And the AGA guidelines are more they don't actually include main duct Ipmn in their analysis. So all different, and that led Bill Brugge to write this editorial a few years ago, which one do we live by? It's not usually straightforward. So what I've tried to do for the purpose of today's talk is not necessarily go over each of these guidelines in detail, but try and give you information that you'll find useful in your daily clinical practice. And in essence, there's 2 main categories you want to think about. One is these patients with cysts that have high risk characteristics, and fairly across all guidelines, there is agreement on this. Those would be symptoms, would be jaundice that you can associate with the cyst, acute pancreatitis, and elevated serum CA19-9 with no other cause. Imaging findings like a mural nodule, which I showed you earlier within the US findings, or a solid component within the cyst, main duct dilation of more than 5 millimeters, and change in the main duct caliber with upstream ductal glandular atrophy, cyst size greater than 3 centimeters, or a rate of change or increase in the cyst size greater than 3 millimeters per year. These are all considered high risk or worrisome features. And of course, in cytology, if there is high-grade dysplasia or pancreatic cancer. This group of patients is fairly standard and easier for everybody to recommend treatment or evaluation. If this comes to you before they've had an endoscopic ultrasound, pretty much these are patients you would send for evaluation to a pancreatic biliary specialist and ultimately perhaps get a surgical consultation. What patients should get endoscopic ultrasound? Guidelines again vary on this. The AGA guideline in general took an approach which was very conservative in terms of both screening, surveillance, and treatment, as opposed to the IAP and the European guidelines, which I think are more central. So the AGA guidelines recommend that you need at least 2 of the following features: a cyst size of greater than 3 centimeters and a nodule or pancreatic dilation. I think that is a little bit of a disservice, and I'm concerned about that, because I think even one of those should be enough to trigger a referral to a specialist. The IAP guidelines, I think, have been good here. Growth rate and some of the things we talked about earlier, they include all of that for reasons for evaluation of the US. And the European guidelines leave it somewhat open, depending, it's, you know, in the sense that if there is something that will change clinical management, then US FNA would be useful. So I think my problem here with, my concern here with the AGA guidelines is that we have you tend to miss patients that have advanced pathology if you follow those guidelines pretty tightly. In practicality, I think a lot of it depends on your local expertise, depends on the quality of the imaging and the MRI, both the machines as well as the readers, and the endosonographer that you might have at your disposal. In the Bay Area, we don't have this issue. We've got excellent people doing US all around. So I would think that you have access to this, to go to US in your vicinity. And these are patients that, you know, I think with the US, I often find information that is additional to MRI, and I would say in purely personal estimate, about 10 to 20% of the time, I find things that have been not seen on MRI. I won't say missed, just not seen, because the imaging is not geared for that. Indications for surgical resection of pancreatic cysts. Again, all the things that we talked about earlier, all the high-risk things, they should all be either be relative or absolute indications. I brought this up to sort of go over the AGA guidelines again, which really recommend surgery for all MCN and for Ipmn, where the pancreatic duct is more than 5 millimeters and a solid component. And I think it leaves out, again, being conservative for surgery. And there's been, I'm going to show you guys this. There's been a few papers that have compared these different guidelines, particularly in the last 3 years. This one from Penn, this one from UPMC, and this one from Amsterdam, comparing Fukuoka 2017 AG and European guidelines. And it's interesting that results, most of them will pick up the dysplastic lesions, except with the AGA guidelines, if you follow them strictly. So what all of these did was went back and looked at their surgical series over a course of about 5 to 10 years, and then went back and applied the guidelines to the beginning to see if they had followed guidelines, where would these patients end up. And both the UPMC and the Amsterdam series show that there's low accuracy of the AGA guidelines in picking up dysplastic lesions. In the Amsterdam group, there were about 12% of the patients who had high-grade dysplasia or cancer would have been missed by the AGA guidelines. Now, on the other hand, you know, the question is, do we overtreat, and lesions that could have been observed, do they end up getting surgery? And I think that's where you cast the net. The Fukuoka and the European guidelines cast a little wider net, so you get a higher sensitivity, but you're going to maybe have some patients that have surgery who could have avoided it, and with the AGA guidelines, you will get the opposite. But because these are guidelines that are meant to pick up dysplastic lesion, and because really this is our chance of curing these patients, I personally am not a fan of the AGA guidelines, and tend to lean more towards the Fukuoka guidelines. I wanted to go back and, yeah, this was the, so all of that is for patients that have symptomatic cysts. But more commonly, more often, you're going to find cysts that are asymptomatic, that are either on imaging on EUS, and now you have to decide what to do about them. And this is a table that compares the different guidelines, the 2017 Fukuoka, ACG, radiology guidelines, European, etc. And I thought the ACG did a nice job here. We don't really use CT much for surveillance because of the radiation exposure. So MRI is the de facto cross-sectional imaging for these lesions, and the ACG guidelines recommend for lesions that are less than 1 centimeter, do it in 2 years. Cysts between 1 and 2 centimeters, MRI every year for 3 years, and then every year for every 2 years for 4 years after that. And the larger cysts and the higher risk ones, that is cysts between 2 to 3 or 3 centimeters, alternate EUS and MRI every 6 months for 3 years, then perhaps yearly for 4, excuse me. and greater than 3 centimeter cysts, EUS and MRI every 6 months for 3 years, then yearly for 4. So I think those guidelines are the simplest, if you will, of the lot. The AGA chose to, in this case, say MRI in 1 year and then every 2 years for 5 years, and then stop if stable. And that's received some criticism from the community because that's where the miss rate starts to happen. These are and the other societies all recommend lifelong surveillance or lifelong till they're surgical candidates. Obviously, once a patient is older and not a candidate anymore, then it makes no sense to survey them. So that's sort of what I do. I follow in this scenario the AGA guidelines for surveillance. Okay, I think we talked about that. So it comes back to then to my original balance versus of preventing versus doing too much harm. And ultimately, you want to send the clinical features and history are still very key. The location of the cyst, the desire of the patient, their overall surgical candidacy is perhaps still the most important. And if you have high risk, worrisome features and they're good surgical candidates, these would be patients you want to send to surgery. And really for everybody else, you want to survey them, particularly if they're still surgical candidates. Now, I know that it was supposed to also cover EPI, but when I was making this talk, I was like, there is just no way that I'd be able to do justice to that. So I intentionally chose to leave that out. So I'm sorry if I couldn't, but I thought it would become too long. So I thought I'll stop here and I can maybe take some questions on that or any of this to wrap the session, the topic up. Thank you.
I wholeheartedly agree with your decision to leave out EPI. So no disagreement there. I think one thing that we see is that the ACG guidelines, Fukuoka, are very good in telling us how frequently to survey as far as yearly MRI, EUS, and the AGA is very informative about when to stop. How do you approach like a middle-aged person who's had a stable cyst for 5 years, say like a 60-year-old with a 20, 30-year life expectancy who's had a stable 2.5 centimeter cyst for 5 years?
Yeah, I mean, if you're sure it's a branch duct Ipmn, which I think is what you're referring to, I go to MRI every 2 years in that scenario. I have then now started to push it out to 3 years if they've been stable, but I don't stop surveillance till they'd be older. And that's because we know these cysts can transform 8-10 years down the line. And if it's a healthy person, they're 65 and up, they've got this plastic cyst, that's where you could help them. A little bit of it also is the location of the cyst. Frankly, if you've got a 3, 2.5 is probably on the border, but if you've got a 3.5 centimeter cyst that's in the tail, and he's 60, he's in good health, and is tired of getting imaging, you could consider laparoscopic distal pancreatectomy in that scenario. But if it's in the body or if it's in the head, I would not send them for a Whipple. I'd send them for surveillance, but I would keep going. I might feel as it goes more comfortable between 2 and 3 years. I haven't really gone beyond 3 years.
Got it. All right. And then one other question was, do you change your surveillance if they're on immunosuppression? Say they're like a post-transplant patient or they're on immunosuppression for IBD or something?
That's an excellent question. I do. And it's anecdotal. It's a gestalt feeling that maybe being on immunosuppression chronically does increase your risk of cancer. So I do. I'm more vigilant. I don't have guidelines to share with you on every patient. But it's a patient-to-patient thing. But if it's a patient with a cyst that's more than 2 centimeters and they're immunosuppression, I would go at least annually for some kind of surveillance. I might even consider alternating EUS and MRI, 1 year EUS, 1 year MRI in those patients. And again, that's because I think in my personal experience, I feel like I pick up things that sometimes the MRI misses, particularly mural nodules, particularly ductal changes, caliber changes, small tumors. I don't know if MRIs can always pick those up. So alternating that scenario with the US MRI is useful.
Great. Thank you so much, Yasser. Really great talk. A lot to put into a short presentation. So you did an excellent job. Thanks again.